What is going on, everyone? This is Dr. Josh Funk, and you are listening to the Strength and Knowledge Podcast.
What's up, everyone? It's Dr. Zach Baker here, and I have got Bami Adu, one of our 2 sports residents here at Rehab, to perform with us, ready to do another journal article review. And these follow the theme of the residents selecting an article that matches up with the topic that we're learning in the classroom with residency. And this month, we've gotten into more of our emergency management. And speaking candidly, I am PT by trade, and my undergraduate degree is in exercise science. I am SCS certified, but I do not have that definitive athletic training background. So when we cover this material in our residency, we bring in Megan Gray, who is our athletic trainer employed through Rehab to perform, who her full-time position is over at St. John's Catholic Prep, but she also does a variety of other things with professional, collegiate, and youth club sports organizations as well. So when we get into this material, we usually defer to her and her experience and expertise in the classroom. But I'm going to be facilitating the conversation today. And Bami, do you mind just giving the listeners the title of the article that you selected and really why you thought it was interesting?
Yeah, so the title of the article is Perceived Management of Acute Sports Injuries and Medical Conditions by Athletic Trainers and Physical Therapists. And I thought this was interesting because, during the sports residency, you have a lot of times with other ATs and other PTs on staff. And as a resident, you're kind of just following the AT around and kind of helping them out. And even when they go out on the field, you're not really providing that emergency care, but you're with the ATs when they do that. So I guess the reason why I thought this was cool was that you get to see kind of where the delineation is between PTs and ATs in an emergency situation. And when we get into this article, I think it does a really good job of kind of saying what an AT role is, what a PT role is, and kind of the gray zone, like, do ATs feel comfortable dealing with these situations? Do PT feel comfortable, or do just none of them at all really feel comfortable? So I'm excited about this one. It has a lot to do with the rest that we're going through right now, so it'll be a good one to get into.
No, and I agree. And for any PTs who are interested getting into, quote unquote sports PT or having a hybrid role where they are going to have some athletic training responsibilities, I think it's very important to note that until you actually get firsthand experience with what that looks like, you're a little bit unfamiliar with what that entire role and responsibility entails. And it's one thing to be able to recognize an injury and understand what the acute evaluation, diagnostics, and intervention, or just whatever the next protocol is to follow. But it's another thing to be able to do that immediately, on command, out of the blue, which is the field that ATs thrive in. And it's kind of wild to me when you watch them. Ideally, the majority of the practice of the game, they're hopefully not doing anything. But in that split second that something happens, they need to be able to immediately respond. They need to be on their game, and their margin for error with how they can diagnose and handle some of these acute injuries is not nearly as forgiving as what we in the PT field get to deal with if we're working with somebody in the clinic coming off of Achilles tendinopathy or an ankle sprain. You have a little bit more wiggle room with apprehension, hesitation, and maybe second-guessing yourself, where in the moment on the field, you've got to be there and you've got to be accurate and you need to be confident and competent. Bami, do you mind going into a little bit about the article? Just kind of give us a rundown of how it was set up, what they were looking to find.
Yeah, so the objective of the article was to compare the perceived preparedness and decision-making related to acute injury and medical conditions among ATs and PTs, and then evaluate the relationship between perceived preparedness and their decision-making. This was done in a cross-sectional study, so use like an online survey for this one. The patient population, they got 292 athletic trainers, 317 physical therapists. The physical therapists they got was a mixture of SCS certified and regular physical therapists. As we go through the results, it kind of shows you which one was a physical therapist and which one was a SCS certified. And then they had 46 dual-credentialed PT and ATs. The 46 credentialed PT ATs were not considered in the analysis of the study. And these were all PTs out of Ohio. So inclusion criteria, any licensed AT or PT in the state of Ohio, and then exclusion criteria, they didn't allow any students or PTAs in the study. So for intervention, what they looked at, so the online survey had demographic questions, and then they just had questions related to coverage responsibilities. And then they had, majority of their questions was kind of rated for a preparedness scale on a 5-point scale, 1 being prepared, 2 being somewhat prepared, 3 being neutral, 4 being somewhat unprepared, and 5 being not prepared. And then the participants were presented with a set of case scenarios. So kind of just a case scenario, like what would you do in this situation? And it wasn't just like, what would you do if someone dislocated and got out of the game? It's more like in-depth was, this person's a starter or they're not a starter, or this was their second dislocation or the third or the first dislocation. So a bit more in-depth, and they kind of asked the PTs and ATs to kind of rate how prepared they were to kind of handle that situation. After that, they then asked PTs and ATs a different set of questions, and then they wanted to see like how appropriate their answers were. The answer to the questions was from another article where they kind of talked about appropriate answers to emergency situations, and that's where they got their best practice answers from. So some of the answers was hold out and refer, hold out and monitor symptoms, return to competition and monitor, or return to competition and not monitor. So those are the different responses that they could have for some of the other questions. So basically what they found with when it comes to comparison of the perceived preparedness, they first found that at least 75% of ATs felt prepared to respond to an athlete with 9 of the 16 conditions. So the conditions, not going to name all of them, but they're like your sprains, your strains, dislocations, concussions, asthma attacks, heat illnesses, cold illnesses, just those emergent situations that could happen during a sporting event. They also found that over 75% of ATs felt at least somewhat prepared for all 16 of those injuries. So again, some of those more complex injuries were like asthma attacks, concussions. They found that over 75% of PTs felt at least somewhat prepared for just 5 of the 16 injuries and medical conditions. So on average, they found 77% of ATs felt prepared, while only 34% of PTs felt prepared. 8% of PTs felt not prepared, while only less than 1% of ATs felt not prepared. They also looked at, and they saw that 75% of the SCS certified PTs responded as being at least somewhat prepared for 14 of the 16 categories. But this was not, and the only two that they weren't prepared with was concussions and asthma attacks. So then when they looked at comparison of responses to acute scenarios, they found that ATs provided more inappropriate than appropriate responses for 3 of the case scenarios, but they also found the same thing with PTs as well, which we'll get into more of that a little bit later. And then they found over 75% of ATs responded either appropriately or overly cautious to 11 case scenarios, while over 75% of PTs responded appropriately or overly cautious to 9 case scenarios. And then they looked at the correlation between perceived preparedness and then appropriateness. So if they're really prepared, how appropriate were their response? Unfortunately, they found no correlation with that. So just because some ATs and PTs felt really prepared to handle a certain situation, it wasn't always the appropriate answer that they chose. And that kind of gets into the big summary of this article, right, is that, yes, ATs perceive themselves to be more prepared for the management of acute injuries and medical conditions compared to PTs. They also found that SCS PTs had a higher purported or perceived preparedness in comparison to their non-SCS PT colleagues. But in total, they found that there's really no connection between preparedness and appropriateness when dealing with the plan of care for that patient.
That's a lot to unpack there, and I think we could go a variety of different ways with that information. And I love the fact that they had the self-perception of preparedness, but I would like to imagine if anybody has gone through and gotten their license or their degree in a field, I hope they feel prepared. But as you mentioned, this shows that there wasn't necessarily a correlation between how well they thought they were prepared and what their actual clinical decision-making kind of model would look like with that. And I think that really comes down to experience and exposure and being out, getting the reps, and just understanding how does theory translate to practice. And that's no different than going through PT school, learning everything in a textbook of what something should look like, what it should respond to, and then going out and figuring out, does it actually play out that way in real life? I love the part how they gave them the case scenarios and having some of the extra wrinkles in those case scenarios. And hey, here's a shoulder dislocation, but maybe it's their second or maybe it's their third one. Or is this a player who is coming off the bench and may not get any playing time? Or is this the starting quarterback or starting center fielder or whatever it may be? It's no different than in the clinic where you have somebody that comes in with a maybe mild or moderate injury, and you give them their response, and then they follow back up with, oh, well, I have a practice tonight. Do you think I can play? Or, oh, I have playoffs this weekend. Do you think I'll be ready? And they give you that little extra bit of information, and it makes you second guess yourself. Like, oh, am I being too conservative or too aggressive with this? And if I would have known that information from the beginning, would I have changed maybe what I did from a testing standpoint or getting some other information regarding their status? So I'm glad that the case scenarios did have a little bit of depth to them as well.
Yeah, and I think the interesting thing about this case was that the part that was interesting the most to me was that just because you're prepared doesn't mean you always answered appropriately. And, as a PT, I'm watching a lot of ATs, so you're always thinking, like, that is the most appropriate response that they're doing. And then it's kind of interesting to see that, like, even at that level, right, there's still more continuing, there's still more different experience that we need to get in order to feel completely prepared and appropriate in handling those situations. As a PT in that field, we have a little bit of background knowledge of the emergency care, right? I mean, this article proves that PTs do have some of that background knowledge, and they are somewhat prepared, but we're also not engulfed in that on a daily basis, right? So that opens a door now for, if you're a PT who wants to work in sports, right, based off this article, we're not as prepared as we should be, right? So what other things are we doing to get that preparedness, right? How are we going to get that bit of exposure to emergency situations if we're in the clinic treating patients all the time?
Yeah, and I think the example that I always give, and when we go through residency and we have residents spending time with ATs, getting their sports venue coverage hours, there's a difference between knowing the material and a difference between acting on that material. And the example that I always give is, I'm CPR certified. I've gone through the EMR course. My wife is a nurse, and she worked in a hospital where they would have a lot of situations where they were calling codes and they were doing CPR. And if something were to happen in our house or out in the public and both of us were present, we are on paper equally certified or credentialed to handle the situation. Her ability to act immediately and confidently would exceed mine because she's done that scenario probably more times than she can count, whereas I've done the scenario as many times in my career as I can count on my two hands. So that level of experience and what that brings to the table, I think, cannot go really unnoticed with that.
Yeah, I think you hit the nail on the head there. Just understand like where your role is and kind of how to utilize the people around you in order to handle an emergency situation. And the situation that they gave, kind of like you mentioned, they did add some of that wrinkle to those situations. And I think they did that just to show that, like, if it was a textbook definition of an emergency situation, most of us would probably get it right? Whether you're a PT or an AT, I think most would get it right. But when they add other situations to it, like, okay, dislocation is a big deal, but it's a recurrent one. They're in the playoff game, this, that, and the third. Now it's that clinical decision-making aspect of it, right? And like you said, that just comes with more experience rather than just like passing your board exam and working for a year. That just comes with more experience over time and people you associate yourself with as well.
Definitely. I think a lot of times when you mentioned in here, they talked about giving the most appropriate response. And were they accurate in that or were they not accurate? I think sometimes the appropriateness of the response, or like in a PT world, the efficacy of your plan of care, it's kind of a hindsight's 20/20 situation where you can always retroactively look back and say, could I have done things different? Could I have done things better? But given the information we had that day, did I make a logical and appropriate decision? And I think when you look at the level of appropriateness with some of these more urgent conditions and urgent scenarios, I think the first thing you always have to look at is, are we identifying red flags and are we identifying situations where if we do not make a certain decision, outcomes could be catastrophic or tragic, or they could progressively and significantly worsen. So I think there's like a baseline level of appropriateness of, can we identify these situations and make sure that we have our protocol ready to go and we're acting on it? Then I think you get into that next tier of like, was this a good decision or was it the best decision? And I think that's where you start to think about, am I returning them to play? And if I am, what is the level of risk that they're entailing? And then the second part, with that risk, whether it's identified as low, medium, or high, is it been informed? And is the individual who you are making this decision with, are they aware of the level of risk? Are they comfortable with it? And where does that conversation go from there? And in some situations, you may be the only person involved in that conversation. In others, you may be on the field, but you also have the luxury of having 2 or 3 team physicians on the sideline as well that you can consult and get their input with as well. So I think a lot of this is going to go hand in hand with, are you in a professional environment, a collegiate environment, the differences between a junior college versus a Division I at a Power 5 school. Your resources are going to be vastly different there. Or are you a sole practitioner at maybe a local club soccer tournament where you've got 15 to 20 teams there and you're the only individual? I think all of those different factors are going to play a level in how confident are you and how cautious or aggressive are you being. You may err on the side of being overly conservative if you're in a position where your resources are strained, your ability to allocate your time and effort to that person solely is spread out. If you're covering a tournament with 150 athletes, you're probably going to be ultra conservative in your return to play recommendations, because if they return to play and you've got 149 other people to pay attention to, the outcomes may not be as desired.
Yeah, and I think you kind of said it, right? In the article, they found that PTs, that they answered overly cautious for a majority of the situations. And I think that just goes to show you, like, if you're just not as experienced, right, it's not like they're doing something grossly unsafe, right, but it's more so, it's going to err more so on the side of caution. And kind of like you said, right, it just has to do with their experience level. ATs didn't really answer a lot in the overly cautious range, and I think because ATs probably were more so comfortable in that realm when it has to do with emergency situations. So kind of like what you just said too, and it's kind of interesting how they kind of looked at every single answer, and also they kind of analyzed it. I did wish that they did see what PTs and ATs did, the dual certification, and how that went in, but the article mentioned they couldn't do that because that would kind of like, it would be hard to get a really true statistical analysis on that if you had dual credentialed. And they also didn't go more into detail about SES PTs versus ATs and PTs. I think that's another part of the research I'd love to see too, a dual credentialed and then also an SES PT and how they kind of fit in with ATs and PTs in this article.
I'd be very interested to see as well with the appropriateness of the response, or if they were leaning towards being more aggressive or more conservative, how much the environment that they were functioning in would play a role in that. And you think about, there's a difference between making a recommendation to a ninth grader at a recreational soccer tournament versus a professional NBA player in Game 4 of the championship. And the difference between being too cautious there is, all right, well, the high school player just misses an extra game or so. Whereas in the professional environment, maybe we were too cautious. We didn't let that player play. Now their team lost. Now they lost the championship. Now they lost all on millions of dollars of signing bonuses and other performance-based incentives in their contract. It's always interesting to me when you add that level into it, how does that influence decision-making? Should it influence decision-making, and what ultimately plays out there? And I think it's tough. It's a hard hat to wear. We've had this conversation personally, just as you're navigating residency and what you want to do following residency. It's hard enough just to handle the health and PT and rehab and AT aspects of the residency. When you add in all those extra pressures, is that something that you want to handle first year in your career, or is that something that you need more experience with? And it's a job that I have tremendous respect for the people who are in those positions, because they have to answer a lot of questions that personally I don't know how comfortable I would feel answering those until I had more repetitions and more time in that environment.
Yeah, it's kind of funny. I was actually reading some of the questions myself and trying to see what I would have answered there. And my whole response was, it depends. Like, it's so hard to actually get a true answer. Like you said, like, it did a good job at throwing in some wrinkles, but then there's still so much more to the puzzle that I would have loved to see how it would, like, honestly answer. But, that was part of the biggest take was, I mean, it's a great article, but you can still appreciate the fact that there is some other parts of the questions that you just don't see. And then it's really hard to answer honestly when you just don't get the full picture.
Yeah. And it depends is not the answer that the head coach and the owner of the team want to know when their star player's on the sideline. Bami, I appreciate you getting this article. Were there any other just big takeaway points or messages that you think are worth hitting on, or did we cover it?
No, I just think big picture here, continuing education. I think the biggest thing they showed us in this article that there are wrinkles, and that we should always, as a PT or even as an AT, if we're in that emergency situation, if there's something that this article really told us that we don't always act appropriately, right? So just getting good feedback from the people around you, if you're a newer grad or a new clinician, or just, continuing to look up more literature to help you be and answer some of these questions more appropriately.
Yeah, and I think my biggest takeaway from this is it's a lifelong learning process, and there's a lot to be learned from other professions in synergistic fields, meaning, physicians, PTs, strength coaches, athletic trainers. There's going to be a lot of overlap of what we all do. We have a lot of shared roles and responsibilities, and honestly, a lot of shared didactic material that we all go over. But there are definitely some nuances where I think each individual profession has more experience or has more comfort level with. And I think you would be doing yourself a disservice if you did not take the time to learn from these other professions. We're fortunate enough here at R2P. We've got 3 ATs on staff, Megan, Courtney, and Jana, and I encourage our PTs and our residents to try to spend time with each of them, get an idea of what their day-to-day looks like, and I think it's only going to enhance, one, not only being able to learn from them and the stuff that they do that we do not do either at all or on a regular basis, but we're going to see mutual athletes just at different parts of the rehab and injury continuum. And if you can have a better appreciation of what their first encounter with an AT looked like and what that time looks like before they make it into your PT clinic, I think it's only going to make you better as a clinician. So, Bami, I appreciate you taking the time, doing the dirty work, and getting the research articles kind of curated and filtered out for us. And I look forward to seeing what you bring on next month for us.
Thanks, Zach.
Thank you for listening to the Strength and Knowledge Podcast. If you enjoyed this episode or have been tuned in for multiple episodes, we would love for you to subscribe, rate, and give us a review on Apple Podcast or Spotify. Until next time, thanks for listening.